Kareth is here, but thank you to Kareth for facilitating me giving this virtual talk today. So in terms of conflicts of interest, I received a knowledge translation grant from Physician Services Incorporated, and part of that grant is allowing me to spend time on knowledge translation activities such as today's talk, trying to increase awareness and use of SGLT2s and GLP1s. I have no connections to any drug companies. I've never received money from any drug companies, but I have received a couple complaints from drug companies when some of my studies showed side effects of their drugs. I'll leave it at that. A bit about me. I'm a clinician scientist. I work at Sinai Health here in Toronto. I run a research lab. We conduct clinical trials. We develop software and also conduct epidemiologic studies. I've been a locum physician at the Surrey Hospital for 9 years now, so it is very much my longest standing job. And I really love the work in the SU and feel fortunate to be, a part of the team at the Surrey Hospital. I'm also a deputy editor at the New England Journal of Medicine Evidence. This is a new journal within the New England Journal of Medicine family. I think it provides me with an opportunity to, share some editorial insights as well along the way. So 3 cases to keep somewhere in your mind. We'll come back to these cases at the end. So first up, a 74-year-old man, retired physician, BMI of 30, had high blood pressure, drinks 15 standard drinks per week, referred for consideration of a GLP-1. Next up, an 87-year-old woman who was admitted with malaise, difficulty ambulating, and recently was started on semaglutide for type 2 diabetes. And patient 3, a 62-year-old man admitted with heart failure and preserved ejection fraction. Main history is high blood pressure and a BMI of 27. So here's a summary of the data that supports SGLT2s. If you're coming to this talk and you want to learn a lot about physiology, you'll be very disappointed. I want to hit you with the facts, okay? So this table here is a summary of large, double-blind, placebo-controlled randomized trials to review the benefits of SGLT2s for adults with diabetes, as well as those without diabetes. So first up, there have been multiple clinical trials, as you see here, that have shown that SGLT2s compared to placebo lead to approximately a 10% reduction in stroke, heart attack, or death from cardiovascular causes. Remember that every time you prescribe insulin, that does not improve those outcomes. Every time you prescribe a DPP-4 inhibitor, that does not improve these outcomes. So this is why these results were so impressive when they came out. Subsequent trials looked at a composite of heart failure or death from cardiovascular causes. And here are the trials listed in case you're curious. These trials included adults with diabetes as well as those without diabetes. And in general, they showed a 30% relative risk reduction in this outcome of heart failure or CV death and approximately a 5% absolute risk reduction. That's really impressive. We would translate that to say, the number needed to treat is approximately 20, right? So you treat 20 people with these medications over a couple of years, and you reduce one of those events of heart failure or cardiovascular death. Have there been more trials? Absolutely, okay? So there's been a collection of trials looking at how about with adults with chronic kidney disease? Do SGLT2s improve renal outcomes? And the answer is yes, they sure do, okay? Here are some of the trials, the 3 main ones. I will note that EMPA kidney and DAPA kidney, those are the 2 that also included adults without diabetes. And the outcome was a renal composite. It was a little bit messy, and it included whether or not somebody died from a renal cause or a cardiovascular cause, if their GFR fell by more than 50%, as well as a couple other components. And again, you're seeing a pretty impressive absolute risk reduction and relative risk reduction. And then very hot off the press, ventricular tachycardia. There have been 2 clinical trials that have looked at among patients who have heart failure and maybe they have an ICD and CRT, do SGLT2s compared to placebo reduce the risk of ventricular tachycardia? And as you can see here, the answer is yes. That's impressive because tachycardia, pardon me, is life-threatening. And that is one of the reasons why patients with heart failure die. I'll pause for a moment before I keep trucking along, but this is the summary of, I would argue, the most important trials related to SGLT2 inhibitors. Okay, no questions yet. Let me scroll down in the chat. Okay, I will keep going. So next up, GLP1s. Again, this is a summary slide. I don't want to teach you physiology. I want to hit you with the facts. So here are the trials for GLP1s, in particular semaglutide. Why did I pick semaglutide? That's the most commonly prescribed GLP-1 in Ontario, and I would argue it has the clearest benefits. So again, these were blinded placebo-controlled trials. First up, again, the outcome of stroke, heart attack, or death from cardiovascular causes. For the study of adults with diabetes, we saw a 2% absolute risk reduction. That's pretty impressive. And then a study in adults who were obese who did not have diabetes. This was a blockbuster trial because there are really no other treatments for obesity that lead to a reduction in that person's risk of heart attack, stroke, or death from cardiovascular causes. The heart failure literature, it isn't quite as impressive as it is for SGLT2s. So most of the trials have been with preserved ejection fraction. Here are the names of the two main trials here. Their outcome, it wasn't, I would argue, quite as robust as the SGLT2 trials. They looked at this Kansas City questionnaire that got at many different aspects of quality of life. Don't get me wrong, quality of life is very important, but it's not quite as hard of an endpoint as, say, what we saw in the SGLT2 trials. But certainly there is an improvement in the burden of symptoms that patients have. How about renal outcomes? So the main trial is the FLOW trial. This was for adults with diabetes, and you saw a 25% reduction in renal composite outcome and a 4% absolute risk reduction in that outcome. So again, pretty impressive stuff here. And if you were to ask me if I would have expected this trial to be positive, I would have said no, probably not. But add that to the list of times that I've been wrong. And then recently, there have been additional trials. The most recent and relevant is you have patients who have osteoarthritis secondary to obesity, and isn't GLP-1 like semaglutide? Does it improve their symptoms? And as you can see here, it led to a 40-point reduction in the WOMAC pain score. What on earth is a WOMAC pain score? Too much information, but a validated a pain scoring system used for osteoarthritis trials. And you might be like, well, 40-point reduction, like, is that good? Is that not so good? It's pretty good. If you have a joint replacement, like a hip replacement or a knee replacement, generally patients report like a 30-point reduction in their WOMAC pain score. So hopefully that contextualizes it. If people can just mute themselves, that would be great. Somebody's clicking away in the background. Any burning questions about this slide before I keep going? No? Okay, cool. So are we prescribing these to our GIM patients, the patients we care for on the wards every day? No, we aren't. How about some data? So this is a study from 16 hospitals in Ontario from 2015 to 2022. It looked at 1.3 million patients hospitalized. 31% had diabetes, 26% had obesity, and 36% had cardiovascular disease. So how many got a GLP-1? Not many. 0.1% at the time of discharge were prescribed a GLP-1. How about an SGLT2? Better, but still not great. And then we can contrast that with a sulfonylurea. As I think everyone at this talk knows, sulfonylurea is do not improve a person's risk of heart attack or stroke. And we know it causes both weight gain and hypoglycemia. So hopefully this sort of nicely summarizes the need for knowledge translation and why I'm excited to try to do some work in this space. This study was led by Prachi Ray. She's now a first-year medical student at Queen's University, and it was her master's thesis and recently published in the Canadian Journal of Diabetes. So I want to now just spend some time giving you the basics of SGLT2s. So it's a once-a-day pill. Most often I'm prescribing empagliflozin. It's 10 milligrams daily. If you forget that, empagliflozin is like almost 10 letters. So 10 milligrams once a day. Uh, Initially, SGLT2s were identified as a treatment for type 2 diabetes. And when I'm teaching medical students and residents, I say, the SGLT2s follow the rule of fives. What's the rule of fives? Patients' blood pressure drops by 5 millimeters of mercury, their weight drops by 5 pounds, and their A1C drops by 5%. You wish, okay, 0.5%. So they have a marginal reduction in A1C, but these drugs work really well. Sometimes I've sort of heard physicians say, oh, the A1C barely went down with this drug. We should probably just stop it. It's probably not doing much. And I would argue that is probably wrong and focus on the hard outcomes. Those are more important by how much somebody's A1C drops. If you're giving an SGLT2 to somebody who does not have diabetes, it's not the rule of fives, it's like the rule of twos. So like maybe their blood pressure goes down by 2 millimeters of mercury, maybe their weight drops by 2%, maybe their A1C changes by 0.2%. In general, SGLT2 should be avoided if the GFR is less than 20. However, there's nothing magically different from like a GFR of 17 versus 21. So, use a bit more than just a strict cutoff. And in particular, this is a cutoff for empagliflozin. There's slightly higher cutoffs for dapagliflozin or canagliflozin. But I would argue empagliflozin probably has the best collection of benefits, and it's easier to remember one GFR cutoff as opposed to 3 GFR cutoffs. For the many pharmacists in the room, there's very few drug interactions with SGLT2s. That's because they're not metabolized by any of the CYP enzymes. So that maybe makes your life a little bit easier. The main contraindication for SGLT2s is dialysis. That is the main absolute contraindication. There are some relative contraindications, like if the person has type 1 diabetes, if the person is breastfeeding, and I can answer more questions about that in the question and answer period. How about the risks? So the most common risk you will see is genital infection. This is more common in women.
Okay, we'll see you then. Yes, bye-bye.
Than it is in men. And sorry, if
We'll
people
see you after lunch.
if people can just mute, please. Okay, Brindley, done. Okay, so where was I? Genital infections are most uncommon. If you're prescribing it to a man, you need to ask, are you circumcised? And if they're uncircumcised, they're at a higher risk than a man who is circumcised. So after they go pee, everything has to be dry and clean, okay? Dry and clean, because we know SGLT2s, they cause glucose to be peed out, and glucose is the perfect substrate for yeast. Diabetic ketoacidosis, so a twofold increased relative risk, but more useful is the absolute risk, so 0.2%. And this is primarily confined to adults with type 2 diabetes. So you don't need to worry about this in a person who has heart failure and does not have diabetes. Previously, we got worried about the risk of amputation. That was only seen with canagliflozin, and I would argue there's probably other reasons to avoid canagliflozin anyway. Some debunked risks. So urinary tract infection, I don't think so. Yeast infection, yes. UTI, no. I don't really think that's been shown in the data if you look closely. And these drugs definitely don't cause renal failure. If anything, they reduce a person's risk of renal failure. Because genital infection is the most common risk you might see, I want to talk about, well, how do you treat it? For any family doctors on this call, You know this better than I do, so feel free to correct me. But in general, I'm stopping the SGLT2 for a few days. I'm counseling on good GU hygiene. If it's a man who's uncircumcised, again, everything has to be dry and clean. For women, everything has to be dry and clean after you go pee. Loose-fitting underwear is also helpful. And often I'm finding I'm treating it with just like topical antifungal for a week or two. If it's more severe, maybe 3 days of fluconazole. What are the risk factors for DKA? So remember, in general, it's confined to adults with diabetes. So if the patient does not have diabetes, I do not get worried about DKA. We did this study. This was when I was a grad student because I was curious, like, it's one thing if there's a risk, but I want to know who's at highest risk. So this is a study that we included 111,000 adults who received an SGLT2. Overall, 0.5% developed DKA in the subsequent year. Said differently, 99.5% did not experience DKA. The top 5 risk factors, so by far and away prior DKA. Prior DKA was the biggest driving risk factor, and some other risk factors that you can see here, but this is the big one. And maybe in the question and answer period, I can talk more about like how I act on this when I'm seeing a patient. And then just generally, this is how I counsel patients on an SGLT2. So initially, you might experience some lightheadedness. So if I have an older, frail adult, I spend a lot more time counseling on this. Fortunately, this does go away after a few days. As mentioned, after you go pee, make sure everything is clean and dry. These drugs do not cause hypoglycemia, which is terrific. We don't need to monitor this medication with any labs, which is really nice. A much higher level, pearl for maybe any clinician on the call. If I'm really worried that somebody's at higher risk of DKA, in 4 weeks, I just repeat their bicarbonate. And if their serum bicarbonate is now like 15, that's a gentle tap on your back. They're heading towards DKA, and I would hold the drug, but that's deep in the weeds. There are some other potential benefits of SGLT2s to be aware of. So there are now a half dozen studies that have shown it improves the patient's hemoglobin by approximately 10 points. This is a study we recently did using data from Denmark, where we looked at everyone in Denmark who received an SGLT2, compared it to a DPP-4 inhibitor, and this is approximately what we saw. There are some patients where their hemoglobin goes up much more, but like 20 or 25 points. And think about your patient with chronic kidney disease who maybe like lives at a hemoglobin of 90 and hates taking EPO. This can be pretty meaningful for that patient population. And then they also have been shown to reduce risk of gout. However, this is based on secondary analyses of randomized trials and observational studies. So this is a study that I led again when I was a grad student, where we looked at 300,000 patients with diabetes and looked at the risk of gout if you started on an SGLT2 compared to a DPP-4 inhibitor, and saw a pretty impressive relative risk reduction of gout. A lot of information. I'm going to change gears and talk about GLP-1s. And as mentioned, there'll be at least 10 minutes for questions, but any burning questions about SGLT2s before I keep going? Cool. Okay. Um, so GLP-1s, the mechanism of action, they decrease gastric emptying, so patients feel full longer. They increase satiety, both centrally as well, and increase insulin release. The main indications are adults with type 2 diabetes, or adults with a BMI above 30 or above 27, and they have a comorbidity like high blood pressure, hyperlipidemia. What are the contraindications? A personal or family history of medullary thyroid cancer. How do I bring that to life? I just ask the person, hey, a brother, sister, a mom, a dad, anyone have thyroid cancer? If they say yes to it, it's almost always papillary thyroid cancer because that's just so much more common. And then in gray, a history of MEN2. What's that? Too much information. Don't worry about it. You only see that on your Royal College exam. And then in terms of toxicity, the biggest one is financial. These drugs are expensive. So they are covered for adults who have type 2 diabetes. They are not covered for adults who have obesity. I really hope that changes. And in general, it depends on the pharmacy, but in general, it's approximately $250 per month for a month supply. Gallstones, pretty rare. GI is common. Fatigue is common. I put those two in purple because those are dose related, and I'll explain shortly why that's important. Um, the basics of semaglutide. And as a reminder, there are other GLP-1s like exenatide, lixisenatide. Those are generally short-acting, and then the longer-acting ones like semaglutide, dulaglutide, liraglutide. Too much information, okay? Let's just focus on semaglutide. It's the most commonly prescribed GLP-1, and I'd argue the most effective. So it's a once weekly injection. There is also an oral daily version available. And the key with the weekly injection is slow up titration. If you up titrate patients quickly, you will definitely cause GI side effects. Um, it was initially identified as a treatment for type 2 diabetes, like SGLT2s. Unlike SGLT2s that had that rule of fives, with GLP-1s, they have like the rule of tens, okay? What do I mean by that? On average, blood pressure drops by 10 millimeters of mercury, weight drops by 10%, and A1C drops by 10%. You wish 1.0%. They're safe regardless of eGFR. So one last thing that you need to remember for semaglutide, it can be given at any GFR. Similar to SGLT2s, very few drug interactions. There's no specific lab monitoring that's needed. How do I counsel patients before I start this drug? I say we will start you at the lowest possible dose for the next 4 weeks. And sometimes it's like for 6 weeks if I'm really worried that this patient is going to get GI side effects. So that patients remember to take it. I usually tell them to pair it with some activity. So maybe the patient says, "Oh, every Monday night I watch Netflix." Cool. Right before you watch Netflix, that's when you're going to take your semaglutide. So, pairing medication use with an activity they already do is just much more likely to have better adherence. Although maybe it's not the most fun to give yourself an injection and then watch Netflix. I say to every patient, you will experience nausea, vomiting, and diarrhea. There's almost a 100% chance you will experience these symptoms. This just helps to set expectations accordingly. Of course, 100% of patients don't experience this. But if you undersell this and then they have the side effects, they're much more likely to stop it, as opposed to if they go in with these expectations and then maybe they have no GI side effects. The drug is not magic, although it seems kind of magical. So I also counsel on diet and exercise. For exercise, I sort of tell them, it's time to get a Fitbit or whatever watch, although I feel like most people have those, and 8,000 steps per day is your new goal, right? It's not enough just to take this medication. It's also about getting in exercise and dietary changes. And then I ask them, hey, like any upcoming surgeries? And usually the patients are like, no. But this is important so that the patient knows if they have a surgery coming up in general, they should stop this drug at least 2 weeks before their surgery. How come? Because remember, these drugs slow gastric emptying. So if grandma has like a knee replacement coming up in 5 days and she just took her GLP-1, there's the potential risk for, like aspiration, especially if her stomach is still full of contents. So coming back to these three cases, so just a reminder, these are the three cases: a 74-year-old retired physician, BMI of 30, 15 standard drinks per week, referred for GLP-1. Let's come back to this patient. So what happened? So weight dropped from 215 pounds to 200 pounds over 12 weeks, which was, great to see. Blood pressure fell by a bit more than the 10 millimeters of mercury. So this is important, especially if you have a patient on multiple antihypertensives. Sometimes you might have to scale back on one of those pills. He also reported his alcohol intake fell to like less than 5 standard drinks per week. And If you look at the literature, there have been multiple small studies which have shown this, that people just don't have the same desire to drink. His wife told him he is snoring less at night. So there is one clinical trial that suggests that a certain GLP-1 is effective for sleep apnea. I can get into the details in the question and answer period. But um, he had significant fatigue when we were at like the 1.5 milligram weekly dose, like really bad. So I just cut his dose in half. Um, and at that dose, the fatigue seemed to have abated. And he said subjectively felt so much better, which was great. So this is that pearl that one side effect of GLP-1s that was seen in the clinical trials is fatigue. And approximately 10% of patients reported this compared to placebo. Patient two, this is an 87-year-old woman that was admitted with malaise. So it took a few days for us to figure out what was going on. And eventually, when we put the pieces together, we saw her ALP was a little bit elevated and she had a bit of abdominal discomfort. We got an abdominal ultrasound and she had a perforated gallstone. It was managed with a percutaneous drain. And we, of course, did not restart her GLP-1. I'll never know with certainty if this was caused by a GLP-1, but this is just that important teaching point that we know there's a higher risk of gallstones with GLP-1s. And then finally, this third patient, a 62-year-old man admitted with heart failure. So this is a patient who I inherited. I took over his care while I was on GIM. And this is not a criticism of the physician before me. It's very common that we are not starting SGLT2s on patients with heart failure. So that is why I'm sort of giving this case. So, I started on empagliflozin, and there is a good clinical trial to show that it is safe and effective to start these drugs in hospital. Sometimes I'll hear people say, oh, let the family doctor start this drug and follow up 4 weeks later. And I'm like, do you know how busy family doctors are? Like, let's make their life easier. Let's start it on discharge, and then they just have to continue the medication. Um, so yeah, many studies have shown that if you look at how often patients who are coming in with heart failure, how often are they started on this drug before discharge? It's less than 20%. So just a couple online resources that I'll share now as I attempt to stop screen sharing. A few that were two sort of tools that were created by my lab, again, in the goal of like knowledge translation activities. Let me see if this works. Okay. So SGLT2rx.com. So you could enter your patient's A1C, and this is meant for doctors and pharmacists. You could enter their GFR, click a couple buttons, and it will give you the general benefits of SGLT2s, as well as the cardiovascular benefits. You can compare it to other drugs. You can look at the relative risks. And then we have a patient FAQ. This was made by a patient partner in concert with a patient partner that you can hand to a patient. And if you forget everything we discussed today, that's all right. It's all contained here. And if you've never prescribed it before, what a sample prescription looks like, as well as the cost. Similarly, another website called glp1-rx.com, and you can click a couple buttons and it will give you the benefits based on the trials that we covered for the patient in front of you. And same thing, what are the common side effects, the rare side effects, sample prescription, etc., as well as like, how do I up titrate it? So hopefully people find this helpful. The sites will be down later this week just for some scheduled maintenance. But yeah, I hope you find this helpful. And then finally, this website called medicinepods.com. I co-host the Roundtable podcast with my brother John, and we release episodes once a week, give or take. But there's other resources as well. So Internet Work, which is a really popular podcast for trainees, rheumatology podcast, podcast on finances. So hopefully people find that information helpful. I'll just go back to my other slide for a second, and then I promise to stop talking and I can answer any questions people have. Okay, here we go. All right, so 5 teaching points. So if you were asleep the whole time or on Instagram or I don't know, now is the time to tune back in and here are 5 teaching points, hopefully to walk away with. So for adults with diabetes, both SGLT2s and GLP1s reduce a person's risk of heart attack, stroke, or death from cardiovascular causes. So these are the drugs that we should be prescribing patients who have diabetes. We should definitely be avoiding sulfonylureas. We should try to be avoiding DPP-4 inhibitors and instead reaching towards medications that we know improve cardiovascular outcomes. Regardless of whether somebody has diabetes, SGLT2s are effective for adults with chronic kidney disease as well as heart failure. And then I also shared with you the recent trials that improved and reduced the risk of VTAC. Semaglutide is effective for adults with type 2 diabetes and CKD, and potentially for adults with heart failure and preserved ejection fraction. But as a reminder, I would say it's not the same slam dunk that, say, the SGLT2 literature is in my mind. The most common side effects of SGLT2s are genital infection and DKA. Reminder, DKA is really for the adult who has diabetes. If you're giving it to somebody who has chronic kidney disease and they don't have diabetes, it's extremely unlikely they're going to get DKA. And then a couple side effects of GLP-1s to remember, GI, which I think is probably what we're most familiar with. Less familiar might be the fact that they can cause fatigue and sometimes gallstones. And then one tip, so there's a lot of pharmacists on the call today. Doctors trust pharmacists, okay? You know more about medications than we do. Whenever I'm on service and the resident says to me, oh, the pharmacist said we should do insert anything, should we do this? I say, yes, just do as we're told. The pharmacist is right. So, especially for pharmacists that work in the inpatient setting, if you see patients who might be eligible for these medications, I would say, let the doctor know. And then finally, one thing I've always struggled with is how to stay up to date with the literature. It's really hard, almost impossible. As I mentioned, my research team likes to create software tools. So we created this software tool called PaperScrape. It monitors PubMed for clinical trials. It also can scrape data from clinicaltrials.gov. And then we put a call to ChatGPT, and then it summarizes trials in generally 4 or 5 sentences or less. So I'll put the link in the chat, totally free to use. And hopefully people find it helpful to try to stay up to date with clinical trials. That's it for me. And we have, as promised, 10 minutes left for questions. So I'd be happy to answer any questions people